There we go. Thank you very much, Edward, for this kind presentation. It's a pleasure to be here with Dr. Jeff Keogh to present the project that we've been co-leading for the past year and on which yourself, Edward, is a participant. So these are our disclosures. And radiation dermatitis. These are radiation-induced skin changes that pathophysiologically happen with an inflammatory response, that microvascular damage, injury to the basal layer of skin cells, which usually rapidly proliferate and are thus radiation sensitive. And ultimately, we lose the barrier function of the skin and the immune function of the skin. So this is the basic rad dermatitis. How do we see it? Well, radiation skin changes, we see them acute and chronic. So I'm going to call them changes here because it's more than just dermatitis. So acutely, depending on obviously the dose, desquamation, erythema, pruritus, bleeding, ulceration. And long-term, the skin and the subcutaneous tissues can also be affected by radiation, as you can see on the table. And is it common? So we're going to talk a lot about breast cancer today because that was the focus of the Delphi exercise that we've done that we're going to be presenting. So yes, radiation dermatitis is very common, and it is very common in breast cancer. If you look at just the gross numbers, this is the biggest patient population that you'll see with radiation dermatitis because it's also very common. You can look at many different studies, and you're looking that a majority of patients will get some sort of dermatitis after radiation to the breast. And that can vary, obviously, depending on the dose, the fractionation, patient size, where are we treating, and is there any concurrent treatments being given, which can worsen the dermatitis. So what about the onset? So this graph might be more showing what can happen in 2 gray equivalent doses. We know that with hypofractionation, things change. The onset can even be after the end of radiation and ultra hypofractionation. So between 26 and 5 and 40 and 15, we're looking at peaks at 2-3 weeks post start of radiotherapy and before things start to get better. And how do we define it? So to help us study it, to help us define it and treat it, we have definitions. The most common ones are the CTCAE and RTOG. I'm sure all of you know them. They're quite similar, starting with faint erythema and then more brisk erythema, moist desquamation, either in the folds or more general. And ultimately, we're looking at bleeding and ulceration. So these are the grades. More interestingly, and more used is the RISRAS score, which will actually take into account not only what the clinician sees, so those are the first 4 rows, but also a patient component and how the patient feels. And this scale is being used more and more in research. So what does it look like? Very quickly, that's grade 1 dermatitis, so faint erythema. Grade 2, we're seeing brisk erythema or moist desquamation at the folds. Grade 3, moist desquamations will be on non-fold type of surfaces. And as we go forward, we can see ulceration and bleeding. Chronic radiation changes that we do not call dermatitis in radiation oncology. Minor, here you could see on the left some minor hyperpigmentation, hypopigmentation, or telangiectasia. So why is radiation dermatitis important? For many reasons. Two of them are the fact that dermatitis affects quality of life of the patients, and dermatitis can also cause, sorry about that, I got interrupted. So dermatitis affects quality of life of the patients, and in certain cases, if it's very important, it can cause interruption of treatment and worse oncologic outcomes. So it is seen as such an important condition caused by radiation that radiation oncologists, therapists, and radiation oncology nurses develop an expertise, and most of the societies, local, national, international, develop guidelines for the prevention and management of dermatitis. And I'm showing you a few. This is the one from the UK, the Society and College of Radiographers, 200 pages on practice guidelines for dermatitis. CASMO was a group of oncologists, radiation oncologists, who also published several papers on the management and prevention of dermatitis. These were their high-level guidelines, and we'll come back to the guidelines very soon, because all of these guidelines, they to a certain extent resemble each other. These are our local guidelines at the MUHC. I'm just obviously showing one page. We can see the same being done in different provinces in the country, and that's, for example, the BC guidelines. And so what started our projects last fall, 2013, like Ed was just saying, is the fact that a few months before, the MASC, the Multinational Association of Supportive Care in Cancer, published in the Lancet Oncology international consensus-based recommendations on the prevention and management of acute radiation dermatitis. You could see, you'll probably recognize colleagues as part of the authors of these guidelines. And several of us here in Canada were surprised by the recommendations because they didn't align with what we do here in Canada. And I'll give you the word that actually we found surprising is that even olive oil, putting olive oil on the skin was one of the recommendations, something none of us in Canada did and expected. So the question that came up was, does this represent the Canadian reality? Or even more, what is actually the Canadian reality? So we decided to do a project in Canada with a Canadian perspective, knowing that maybe we don't do the same across the country. And the idea of having a Canadian-wide consensus might help homogenize the practice in Canada. We were already a year after the publication, so probably even longer after when they started doing their project. So it was a good idea also to update, see what was happening. And we wanted to focus on breast cancer, one of the most common cancers in which dermatitis happens often. So I'm going to start presenting our project, and Dr. Ko in a dozen slides will take over. So this was a pan-Canadian project, and breast cancer experts from most provinces and regions were represented. You can see it here on the map, and you'll recognize colleagues from all the main centers, or most of the main centers in the country. And this project, I have to thank our sponsor, because La Roche-Posay Canada, with an unrestricted educational grant, allowed us to do that project. So how did we guide ourselves? We were not going to reinvent the wheel. We actually used the project of the MASC as our guide. We wanted to do the same type of methodology, pretty much, not completely, using Canadian experts and reviewing the data for breast cancer. So we divided the treatment categories in the same treatment categories that were done in the MASK project. You can see them there because we were going to look at everything that had been tested up to now. So NSAIDs, corticosteroids, films, dressings, moisturizers, antibiotics, and looking, obviously, like in the MASK paper, at prevention and management. So how did we do the literature review? Again, MASK process is on the right, and we did the same thing. They had already done and published their own literature review, and we continued and updated that review, got all the studies, filtered them for breast cancer, and started analyzing them. You could see here the type of review that was done, quite thorough, where we looked at all the studies for prevention and for management. We looked at the reference, the intervention, the comparison, the outcome, findings, what type of radiation was done, and were there any radiation modifiers involved. We also rated the quality, like MASK did, inadequate, doubtful, and unknown. Obviously, in this type of field, it is a lot more difficult to find very high quality data. So the quality played an important role in how we assessed the evidence. And we went through a modified Delphi exercise. I will present round one, which was more theoretical, and then Jeff will go and really dig deep in rounds 2, 3, 4 and show you what we ended up finding. So round one was divided in round 1A and round 1B, and every round was divided in A and B, A for prevention and B for management, because those are completely different topics within dermatitis. We looked at the categories that you see here. We met in person for round one, like Edward said, a year ago in Montreal. And there was a vote done on how we felt the quality of the data, would the data and the quality of the data for every single agent push us to either the quality was towards recommending, support the use, the data supported the use of a product, or maybe even did not support and was against the use of a product. So here you could see that was the exact question. Rate the intervention for the prevention or management, round A and B, of acute radiation dermatitis. So is the data towards recommendation and support, suggestion and support, recommendation against the use of a product, or suggestion against the use of a product, or no guideline possible, whether for support or against? So using very similar questions. And the scientific part, there was a level of agreement, consensus specification. We needed to have 75% level of agreement amongst the 19 participants. Near consensus was 60 to 74. I didn't add, when I showed you the list, I should have added that the participants were mainly radiation oncologists, but also radiation oncology nurses specialized in wound care. And we also had a dermatologist and an oncodermatologist to give us the dermatology point of view on the board. So we really wanted to be multidisciplinary. Obviously, if we're trying to aim for 75% consensus, we had to collapse the similar options. So For round one, which is just the first round, support became one category when we were analyzing the data, and against the use of the product was a second category. So prevention was run. So that's when we collapsed support and use was run. 60 interventions were looked at. And this is the type of tables we developed. You could see all the interventions here in the blue row, second row, third row, fourth row. And you could see right away the ones that reached consensus, and I'll present them in the next slide. You could see a few of them in green. The ones that reached consensus against their use in red. And then you could see near consensus in, for example, the orange color. So what did we reach at round one? So there was consensus was reached for the recommendation or suggestion in support of 4 interventions. This is in prevention. Moisturizers, gels, and emollients, mometazone, Mepitel film, and skin washing. So this is what was felt that the data was there to support. The data was there to support not using oral celecoxib and alkaline water according to the panelists. And there was near consensus for 7 interventions. You could see them here. And near consensus against the use of 12 interventions that you can see here. So that was round 1A for prevention. Round 1B for management. You have only 14 interventions. Why? Because the literature is very biased towards prevention. This is where most studies are, and not management. And you can see in green Mepilex light dressing, and then you can see here a few other near consensus, either for or against. So what does it look like? Mepilex light was supported. Near consensus was for doxepin, and near consensus against was reached for oil, with honey at 58%. By the way, the percentage is what the vote was. So this is where we stood after round one, which was a way more theoretical round. And Jeff will now present to you actually where we get into what we would do in clinic, which is round two.
Awesome. Thanks, Tarek. Thanks for that background on radiation dermatitis and the background on the methodology, and welcome everybody. And thanks, Edward, for this opportunity to speak at Sunnybrook virtually, and everyone around the world for attending, and of course, Roche-Posay for funding this research. So round two, so as Tarek had alluded to, round one was really focused on the evidence for the interventions, either recommendation or suggestion in support of use of or against those interventions. Round two is, what do you actually do? Taking into account, so hopefully I can advance this. Okay. Taking into account, what you do in clinical practice and the body of evidence that we reviewed in round one. So we took the approach from the mass process, but kind of modified it or tweaked it slightly just to introduce an element of a novelty. Rather than just asking whether you recommend an intervention in your clinical practice for the prevention or management of acute radiation dermatitis, but for the prevention side, whether you would recommend this product in low-risk settings or high-risk settings or both. And we made a distinction between low and high-risk categories based on, the two landmark or pivotal randomized controlled trials, that being Alice Ho's mometazone trial and Edward Chow's Mepitel trial. And so we used their definitions of what constituted high risk for use of mometasone and Mepitone. And for mometasone, as the study was conducted in the US, it was typically post-mastectomy radiotherapy used in conventional fractionation to 50 gray with bolus, with or without reconstruction. And they found a significant reduction in moist desquamation with the mometasone. And then in Edwards' paper, there was more adjuvant breast than post-mastectomy radiotherapy, some use of bolus, but the majority, over 90%, received the Canadian standard of moderate hypofractionation. And they also found a significant reduction in moist desquamation with the use of Mepitone film. So that set the pretense for high versus low risk, and anything else was considered low risk. And we left it subjective to people's interpretation of what is low versus high risk, as opposed to a priori defined percentage risk of or probability of dermatitis. So in round two, we added we split up the oil into distinct types of oil, olive oil being one of them, ultra emo oil being another, whatever that is, to be honest, and then other oil blends. And so we had 65 interventions. And what we found was there was consensus again in both the low and high risk settings for moisturizers, gels, and emollients, as well as washing. And there was only the consensus achieved in the high risk setting for Mepitone. And then there was a bunch that received consensus that we would not recommend. And I guess I would highlight, sorry, I'm not sure if I can go back. Okay, beautiful. I would highlight here, and maybe I'll make this in red next time, olive oil, 100%. So that goes against the MASS guidelines. We get a lot of questions from patients about aloe vera, candulula, so those also achieve near 100% consensus against the use or recommendation. Interestingly, photobiomodulation was, recommended in the international guidelines, and yet we achieved 100% consensus that we would not recommend its intervention. And, I think the discussion was more that either unfamiliarity or variation in what photobiomodulation actually is. And then interestingly, 82% voted against the use of Strata XRT, which there's some emerging evidence about that as well. And again, this is one of those things where this is all expert opinion. Okay, what did we almost achieved consensus against as well? 3M Cavalon Durable Barrier Cream as opposed to the film, and then the use of aluminum antiperspirant. And so I want to just make a distinction here that, we specifically asked, whether aluminum antiperspirant actually prevented dermatitis. And there was some interpretation when people were voting this as like, oh, I thought you were asking whether I would allow for the use of aluminum antiperspirant during radiation. So we wanted to clarify that and put that into round three just to make sure that everyone was on the same page about our specific ask. There was no consensus about betamethasone, mometasone, interestingly enough, despite our talk about Alice Ho's paper there. The 3M Cavalon Barrier Film, which is different from the cream, hydrofilm, which is kind of like along the lines of that Strata XRT is one of those barrier films that maybe perhaps isn't as familiar within the Canadian landscape. And then bacterial decolonization, which is also interesting, and prevention care education. Sorry, go back. And so this is a summary of round two for prevention. In terms of management, Mepilex Light was found to be achieving consensus for the management of acute radiation dermatitis and breast cancer. And there was consensus for a bunch of products that we would not recommend. Again, honey and oil being just notable interventions that we would not recommend in Canada. In terms of near consensus, despite round one saying that doxepine, which is a tricyclic antidepressant, suggests that there's evidence in favor to prevent or manage radiation dermatitis, a lot of us wouldn't recommend it. And I think, that just goes down to the fact that, this is an acute or subacute toxicity that putting patients on antidepressants doesn't sit well amongst the Canadian landscape. Also, these dressings there was near consensus that we would not recommend these biological membrane or trichotex dressings. And then there was no consensus about hydrocortisone. So interestingly, I offer hydrocortisone to my patients, and that's just kind of something that I've always done since residency. And, the dermatologist on our panel said that, 0.5%, even 1% is like equivalent to a placebo in some cases. And so, there was no consensus about the use of hydrocortisone. So it'd be interesting when we break open this up for discussion, what people actually do. So this is just a summary of the management. Again, Metholex Light achieving consensus, and then near consensus against these products, and then no consensus about hydrocortisone. So at the end of round 2, we also asked patients, what did we miss in the MASS guideline? What did we miss in your everyday practice in our round 1? And people said saline soaks, urea creams, lifestyle changes. And then what did we miss for the management? And a lot of people use steroids, not just hydrocortisone, but stronger steroids like betamethasone and mometasone. A lot of people use flamazine, or some people use flamazine rather. And there are these things like saline soaks, cold compresses, gauze dressing with Glaxol base, which we use a lot here in Calgary, actually. And then this Restitio restructuring cream and hydrotherapy. And so these were added to round 3. So and further with round 2, we want to introduce another element of novelty and add some pragmatic recommendations because as radiation therapists that might be on the line, radiation oncologists on the line, radiation nurses on the line, you always get the same questions. Can I go in the sun after? Can I shave during treatment? What type of bra should I wear? Can I shower? Can I go swimming? Can I go in the hot tub? And to be honest, there's like a wide variation in answers that patients get from the therapist versus the oncologist, and even in between therapists and in between oncologists and nurses. So round 3, we went through the same vote process to try to break those near consensus or no consensus votes after some further discussion. And again, same thing, low, high risk, both low and high risk. Of course, you don't have to do that for the management because you already have the radiation dermatitis. So then with round 3, prevention care education came out as near consensus with 100%, well, with consensus at 100%. And then near consensus for the steroids, betamethasone and mometasone for the prevention. And then after clarification that we were asking about antiperspirants, whether you would recommend them to prevent dermatitis as opposed to allowing them to be used during treatment, there was consensus that the antiperspirant itself does not prevent dermatitis, but patients are allowed to use them. And then near consensus that against treatment with 3M Kevlar barrier film and bacterial decolonization. And then there was no consensus on the barrier cream and then hydrofilm. So this was the summary of the prevention. There was consensus on prevention care education. And again, whether there's evidence behind that or that is just, good clinical practice. There was near consensus on the use of steroids that, mometasone was the experimental arm in Alice Ho's paper. Betamethasone is an alternative steroid, again, different concentrations. And then no consensus about the 3M Kevlar barrier cream and hydrofilm. And then near consensus against bacterial decolonization and the barrier film. In terms of management, we added the steroids, and mometasone and betamethasone in the management of radiation dermatitis came out as consensus products recommended for use. And then there was consensus against the use of doxepine, again, a tricyclic antidepressant, the biological dressings, the dry dressing, this Restitio restructuring cream, and Hey, Lynn, yeah, thanks. And then hydrotherapy. And so this is near consensus. So interestingly enough, there was near consensus to recommend flamazine. So just take note of that after round 3. And then there was no consensus about steroids. Again, discussion about the potency of hydrocortisone and whether it truly is effective with placebo. Gauze dressings with Glaxol, saline soaks, and cold compresses. I'll get to your question, Michael. I'm just at the end there. It's good to see you there. So in terms of management, there was consensus for the use of steroids. There was near consensus for the use of flamazine, and there was no consensus, as mentioned, for these products. So then we took it to round. So this is just a summary of everything. you talking about? I'm just going to open up the chat real here. We have had a hard time implementing Mepilex despite, Ed's trial is Mepitel film, and Mepilex Light is the dressing or the foam cream used for the management. How many of the experts actually use Mepilex routinely in their institution? So that's a very good question, Mike. While we leave that to the end and open it for discussion, I'm going to close the chat right now. So this is a summary of rounds 2 and 3. So I'm just going to move on to round 4. So round 4 was actually in person. So after that meeting in September at Carroll last year, and before we're heading there this week, we met again in person back in Montreal in May, and this time providing a dermatologist perspective after he looked at those flamazine results. Also provided great nursing perspective on what is actually used, and that's where Michael Locke's question comes into play. Like, how many of us have expertise or experience with Mepitel film for its use, and maybe that's the barrier to implementation and knowledge translation. Further discussion by all, including a review and real-time draft of the pragmatic guidelines. And so we divided the pragmatic guidelines into categories of after radiation care, symptom control, exposure, lifestyle, and patient factors, including ethnicity with non-Caucasian skin reflecting DEI and sex differences, even considering male breast cancer. These were the interventions that achieved near consensus or did not achieve consensus. And so we voted on these again. And these were the results. And what's really interesting is we achieved consensus for mometasone. And again, this kind of reflects Alice's randomized controlled trial. Saline soaks and barrier creams as a general category achieved consensus for the management of dermatitis. Betamethasone, because there's no randomized trial, but is considered an equivalent steroid, achieved near consensus. There was consensus against the 3M Catalan films and creams and bacterial decolonization hydrofilm. And there was a 180 flip from near consensus to recommend silver sulfadiazine or flamazine to consensus against flamazine. And I know Edward had raised some very good points about this, and it was very contentious. And I welcome the discussion at the end of this talk, which we'll give enough time for. And then there was no consensus about hydrocortisone and gauze dressings with Glaxone. We left it at that. So these are the final recommendations in support of our final recommendations in totality. So there was consensus for washing, consensus for moisturizers, consensus for prevention care education in both the low and the high risk setting. There was consensus for mometasone and Mepitel for the high risk setting, and for the management of dermatitis, all the two major steroids, mometasone and betamethasone, barrier creams in general, Mepilex Light, which is again a distinction between Mepitel film, and then saline soaks and cold compresses. Near consensus for betamethasone for high risk prevention, and then no consensus for Glaxol with gauze dressings and hydrocortisone. The list for a consensus against products is quite extensive. They're all listed there, and basically, there's a lot of things, including olive oil and photobiomodulation that was recommended by MASS that we don't recommend in Canada. And then in the management side, I would say the interesting piece would be doxepine, despite the evidence suggesting it, because, again, nobody necessarily wants to prescribe antidepressants for dermatitis. And then flamazine, which is a bit controversial and up for discussion. Just kind of highlighting, this big list down distilled to the more popular items. And so these are the draft pragmatic guidelines. So in the next 5 minutes, because Edward told me I have to stop at 10:45 or in my time, or 12:45 in Toronto and Montreal, and wherever time it is around the world. These are our draft pragmatic recommendations, and we drafted these real time in Montreal, and we have to vet them through the draft manuscript. But basically, cleansing during treatment and for 6 to 8 weeks after treatment, daily or skin washing is permitted. Skin should be washed gently with lukewarm water and a mild, unscented cleanser. We didn't really comment about pH balance there, but that is sometimes an esoteric term. there was a really strong push by the dermatologist to say that washing shouldn't exceed 10 minutes. And using lukewarm water was really emphasized. No exfoliation, again, by the dermatologist. And then skin should be patted down rather than dried off in another way. Cannabinoid oils were not recommended. Skincare, moisturizing at least twice a day. Water-based, unscented, non-comedogenic, hypoallergenic. Products to avoid topical antibiotics. A barrier cream is recommended instead of topical antibiotics. And this is again an issue that I would, it'd be interesting to hear the international, national perspective of silver sulfadiazine or the use of flamazine. And I'd love to hear from you, Michael, because, when I was a resident in London, we use that on occasion, and especially in head and neck cancers. Sun exposure, again, try to minimize sun exposure to the treated area with either proper clothing, use of broad spectrum sunscreen. Again, patients always ask us, these are practical, pragmatic things that there's no evidence for. There isn't a randomized controlled trial of patients undergoing breast radiotherapy that were randomized to swimming either in chlorine or in the lake as opposed to not, or going in the hot tub. And, we said that swimming was not contraindicated unless there was any skin breakdown. But the treated skin should be rinsed off well, especially if they're in chlorinated water or in, natural water. And then hot tubs and saunas should be avoided just because of the heat. Our dermatologist really recommended against anything hot. Shaving should be avoided. Again, this is kind of commonsensical stuff if the skin is irritated. And then the use of electric shaver as opposed to the razor is recommended. Waxing and those types of cream should also be avoided. Clothing, we didn't really want to be prescriptive because there are some patients that kind of have that, are told not to wear a wire, but some find it comfortable as long as there's enough padding. And we really just said, wear what makes it feel comfortable. Again, antidepressants, there's randomized studies to show that there is no impact on the outcomes of patients with undergoing radiation therapy for breast cancer. Again, we kind of kept with the general principles, avoid using smoking and alcohol during treatment, just as a general recommendation. And then, for, certain populations across Canada where the skin is darker, examining those areas in appropriate light and using appropriate language. And that's it. 1 minute early, Edward. So we're just going to open it up for discussion, and perhaps maybe you can moderate and see if there's any questions in the chat. I know some popped up while I was speaking there.
Yeah, so very well done. Thank you very much. And so everyone feel free to put in the chat room or open your video so that you can ask questions. So let's go to address the question from Michael Locke about the Mepitel film. So Jeff and Tarek, what do you guys do in Montreal and Calgary?
Yeah, thanks, Edward, and thanks, Michael. It's great to hear from you. We don't have much experience with Mepitel film, and it's really after meeting Edward and really understanding his trial that we were able to better connected with the supplier. And so we reached out to the company. We got a whole bunch of samples. We reached out to the nurses that you recommended, Rosemary Hill in Vancouver as well, and just to understand what resources are available. Because it's one thing to recommend it to a patient, but it's another thing to kind of tell them, walk them through. It's like, how do you get it? How much is it? How do you apply it? And so there's a bit of a learning curve, to be honest. And we're still in that phase. And I think it's roughly about on their own, the patients are paying about $100 to $150 out of pocket.
Tarek?
So maybe I'll add one thing. Obviously, a film like that, you need to have experience locally to become comfortable to use it. And what we've done, our wound care nurse, skin care nurse, who's very good, she's been using it in some specific situations where we really expect dermatitis to be problematic. That being said, we have decided, after seeing the results of this exercise and obviously the trials that were published, that we want to have a framework in place for the use of Mepitel. So it will come. It will not be for all patients. It will be for patients we believe need it, but we will want to move in that direction.
Yeah. So good question. And there is another question to ask about the lidocaine containing creams. So Jeff and Tarek.
We don't use, and it has not been recommended by our Delphi.
All
I
right.
don't know, Jeff, if you want to add something.
No. I'm just going to respond to Karina's message right here as well.
Okay.
So we'll work on the manuscript. We'll send that to you, Edward, soon, and the rest of our participants to kind of fine-tooth comb the pragmatic draft guidelines, and then see where it gets published. And then, to be honest, it's one of these things where it's expert opinion. It's kind of like which toothpaste brand you recommend sometimes. 3 out of 4 dentists recommend this, and I think this is what this will be. It's 3 out of 4 radiation oncologists / dermatologists / oncology nurses recommend these products, and we'll put in some stuff there about the pragmatic piece as well.
There is another question about the bacterial decolonization. So can you guys talk about that?
Yeah.
Yes. Do you want to go ahead, Jeff? Because it was discussed in the...
Yeah, it was. And I think part of it, and Edward can chime in too, is that, there was a randomized control study that showed a benefit to bacterial decolonization. And, we are actually looking at exploring, trying to see if we can reproduce those results locally with an IIT here in Alberta, because there's some question about whether it was truly effective, and maybe I'm not sure if Edward or Tarek, you guys have experience with bacterial decolonization, but we don't use it routinely or at all outside of this IIT that we're planning.
So I might add a couple of words. When we discussed it at the exercise, it seemed that nobody was doing it yet in Canada. Everybody was aware of the, if I remember well, it was JCO publication. Questions were about how, it's one trial, it's really very, very early data, and people were wondering if we need a little bit more data, possibly more experience before recommending it. So, things are fluid. This is 2024, and maybe in 2 years when people get experience, when there's another trial coming out, when there's real world evidence out there, the recommendation might change. And Edward, you were there, so feel free to also chime in, like Jeff said.
So Henry has just written a letter to the editor about this bacterial decolonization, and it's actually published. So Henry, can you comment on that? Are you still there, Henry?
Hi, everyone.
Hey, Henry.
Hi, thanks, Edward. Yeah, so our letter to editor was not directly to the RCT on bacterial decolonization, but rather on a observational study on the bacterial colonization of patients undergoing radiation therapy. And there was another study published by a European group looking into the bacterial load of patients having severe radiation dermatitis. And we identified some methodological flaws with regards to how the bacterial load changed during radiotherapy. So I think there is still some doubts regarding the mechanism of action of bacterial decolonization in the prevention of radiation dermatitis. So fully agree with everyone that we probably need more studies looking into the mechanism, as well as more clinical studies correlating the outcomes before we can recommend for practice, widespread adoption.
That's very fair. And while we have you on, thank you, Henry, for that. And it's great seeing you again. While we have you on the line, because, our results showed that Mepitel film was achieved consensus for recommendation for high risk prevention, and then Mepilex Light was recommended for the management But, I think, you were working on some systematic review and meta-analysis looking at barrier films in general with hydrofilm and strata XRT, and perhaps there might be more experience internationally with these products, and maybe that's why, again, these recommendations against their use in Canada might reflect a knowledge gap, or perhaps, as Michael Locke had mentioned, unfamiliarity or experience with these products as to not recommend them. Do you think that there's a role for strata XRT or hydrofilm in addition to the Mepitil and the Mepilex Light?
Yeah, so
Yeah,
SF actually has got published quite a lot on the strata XRT, so he can talk about the strata XRT. And I think Henry in Hong Kong and also Tarek in Montreal, the nurses are using the Mepilex light dressing for the management of the radiation dermatitis. So SF first on strata XRT, followed by Henry and Tarek on the Mepilex light dressing. And again, you see like here at Sunnybrook, we don't use the Mepilex light dressing. We use Flamacin. We use Flamacin until recently. We have been challenged by big time at the consensus by the dermatologists. And even they said the burns unit have abandoned the use of Flamacin. So it just looks like that, okay, there is a big discrepancy between the dermatologist and the radiation oncologist. What I really know is 20 years ago, when I first started treating the breast cancer, we used the moisturizer, saline soak, hydrocortisone, and Flamacin. 20 years after that, we are still using it exactly the same. And but despite something showing up that we should change. So SF, are you here? SF is here, okay?
Hi. Nice to see everyone, and thank you for the very nice talk. We and our group has previously performed the systematic review meta-analysis on strata XRT randomized controlled trials. I think the data are quite limited, to be honest. Usually for the breast cancer strata XRT were only 3 randomized controlled trials throughout the world, so many years, but they're all quite small and with unknown quality assurance, and the fractionation were conventional fractionations. It seems that we saw some signals that it may decrease the occurrence of severe, grade 3 or above grade 3, grade 3 acute radiation dermatitis, but cannot be shown to improve grade 2, 3. So and yeah, that's the meta-analysis result. So I agree with the group that it may be a bit controversial to recommend its routine use for prevention. Yeah, also may be quite costly.
Thank you, SF.
I think I would just also like to add one point, is that this is not like chemotherapy data where anything that has to be FDA to be used has to be FDA approved and go through randomized controlled trial. So we have to sort through tons of data of very varying quality, and we must accept non-ideal trials and use products that have been shown to possibly work with intermediate quality data. So we also need to rely on experience, on ease of use, on price to come up with something like that. So this is not, randomized controlled trials, right, left, and center. We always got to remember that.
Yeah, it was eye-opening when and it was great to see you, Karina and Henry, in Mask in France, because the exhibition hall had a lot of cosmetic companies, dermal cosmetic companies there, and and Tarek and I were chatting over dinner. It's like, it's interesting in Europe, like there's just a certain recommendation for a certain product, and it doesn't really come with evidence. It's just kind of like evidence-based. The physician kind of says, I recommend this cream, and there were a lot of products out there for use, and at the end of the day, with this acute radiation dermatitis, it's acute. It's we want to improve patients' quality of life, but it does get better. This is our attempt at trying to provide some standardization to practice across Canada, and hopefully it'll serve as a model to provide more specific information for breast cancer patients as compared to the MASS guidelines.
So having said what I told, the practice has not changed in the last 20 years at Sunnybrook Hospital, but for the last 2 years, I've seen significant changes. And I think that I have to give credit to our radiation therapy department led by Steve Russell, who is on this stage here. There has been a randomized studies that has been published by Danny Vesprini and also Vancouver, showing that patient with big breast, putting them treated in the prone position can reduce the severity of the radiation a lot. In the supine, the radiation dermatitis grade 2-3, 40%. But when it changed into the prone position, it went down to 27%, which is a significant achievement of the reduction of dermatitis. And it all became possible because of the vision of the radiation therapist. Dosimetrists, they make it possible. They devise a technique that we can treat the patient in prone and did a randomized study. So something that I would encourage other centers, look at the contribution of our radiation therapists of making the prone available for patients with big breast. And I think that Henry is doing the systematic review and meta-analysis and will confirm the benefit of the prone. Now, on the Mepitel film, I actually got a lot of the email requests from the patients. They want the Mepitel film looking at the study. They email me. So I said, it needs to go back to your radiation oncologist at your center. And the radiation oncologists obviously have no experience and therefore not able to allow them to use the Mepitel film for the prevention. Now we use, Rosemary did some video for the patient and the family member to learn. But more recently, I was actually very happy of seeing our radiation therapy department seeing the benefit of the Mepitel film. They are going to implement the radiation therapist at the first day of radiation, put the film on the patient. And we have noticed, okay, if for us, we are experienced, it takes 5 to 10 minutes, less than 5 minutes to put on the film. And there is this cost issue right now. The company is writing with the FDA, get the approval in the US, and hopefully eventually the same likewise in Canada. Now, we agree the hydrocortisone cream and Flemicine are of questionable right now. So we are trying to do further studies to see, okay, is there evidence that we should use more potent instead of the hydrocortisone cream and the mepilite lax dressing instead of the Flemicine? But there is more research. But I think the bottom line is because this is dermatitis, we know that 3 to 6 months later, patients all heal and recover, right? So this is not like patients who have the recurrence that we will say, okay, we need to give chemotherapy, we need to do the radiation to prevent the recurrence. Even if you have the side effect, they will all heal. So the nurses would actually be advocate. They said, okay, if there is something to prevent the horrible pain from the dermatitis, why are we not doing it right now, right? Let the patient. And the radiation oncology, we see the patient 3 to 6 months, by that time, everything is over. So I think that, okay, it will be, there is a question here about the radiation recall. Can expert Tarek and Jeff answer this question about the recall dermatitis?
So there's extremely limited data on that. And again, it's stopping the offending agent. Often I see them use steroids to try to blunt a bit what might be an immune-mediated toxicity, let's call it. So that's what we've been seeing. And I agree with Dr. Zeidan with everything that's the new agents and more agents are being given after the radiation. We're going to give during and after the radiation, whether it's PARP inhibitors, whether it's immunotherapy, etc. We are seeing more of that. So that's another topic that needs to be explored.
Yeah, so thank you, Agatha, telling us that Christy used the Mepilex and Flemicine. In view of the time, I'm going to ask the last question asked by Corina in the Netherlands about the PBM. So once we've answered the question, we are going to have this meeting close off because 1 p.m. people have to go back to the clinic. Before everybody goes, I really want to thank the speakers. And I think that there is a lot of enthusiasm about this topic. We are temporarily trying to invite Tarek and Jeff coming back to Toronto in person in February of 2025, we have 2 sponsoring companies that would come to sponsor. So everyone interested, come. I'm sure that we can take 200, 300 people for our guests as well. We just need to find more sponsoring companies. So anyway, there is a lot of interest. We welcome, thank everybody for attending this. The highest record is 58 people attending. This is amazing for the breast dermatitis talk. So I'm going to end by asking our speakers answering the question from Karina. And then afterwards, I thank everybody. And I want to ask Antoinette to record these people, because in January, we'll send out the invitation to all of you guys. You can actually come in person to meet with Tarek and Jeff and take the pictures with them as well. Okay, last question, answer.
Thanks, Edward. I'm looking forward to UC food. So photobiomodulation, it's interesting. We had a colleague from Ottawa and another separate meeting with Chris Dennis, actually, who was Edward Chow's fellow. And Chris was mentioning to us, their experience with photobiomodulation and, in head and neck cancers. And there was some concern about, the very wide variation in the techniques and the products that were available for photobiomodulation, and even concerns about some toxicities. And so, truthfully, I don't think there's much experience with photobiomodulation at least in Canada. Whether there's emerging evidence, there probably needs to be some standardization about the technique and thorough review of the evidence, but we don't have that expertise in Canada.
Good. Okay. Thank you very much, everybody. Okay.
Very much.
Have a great day.
Thanks, Edward.
Bye-bye.
Thanks, Eric.
Thank you. Bye.